Thank you, Dr. Mallika. I'd be speaking on the surgical management of postoperative endophthalmitis. As we know, endophthalmitis poses a significant surgical challenge, and many of these eyes will be completely lost. And even at the best of hands, it is extremely difficult to salvage some of these eyes. First of all, I will be showing about the objectives and when to operate and all those things, and then I will be moving to the videos. So the primary objectives would be to control or eradicate the infection, manage complications, and if possible, restore vision. The secondary objectives are basically symptomatic relief, prevention of further spread of infections like panophthalmitis, and maintain globe integrity. The mainstay of treatment, of course, is intravitreal injections. Vitrectomy is always second line, but it is indicated in the select group of patients. Advantages is that it reduces the infectious, toxic, and inflammatory load and provides adequate undiluted specimen for culture and sensitivity and other studies, increases antibiotic concentrations within the eye, and by removing media opacities enables a more rapid visual recovery. It not only salvages the eye but also helps to retain useful vision. But it is technically more demanding. It needs expertise and experience. Even a small hitch can lead to complications which are potentially blinding, like retinal detachment. And it is not always rewarding, because even if the anatomical outcome is good, sometimes the functional outcome may be poor. However, results have improved over the years. Vitrectomy may be necessary in two circumstances. Either it's primary, that is when at the height of infection. These two pictures, if you see, are taken about 3 hours apart, and you can see the change that this cornea has underwent in the 3 hours. So primarily, when infection is actively spreading, that is one time when you require vitrectomy. And the secondary, in the resolve phase, when there is a lot of vitreous opacities, and to remove these membranes for visual reasons, we may require it. So the questions are whom to offer, when to do, what to do, and how much to do. Endophthalmitis vitrectomy study has told us that hand movements at 1 meter or less vision is what is an indication for vitrectomy. If there is a retinal detachment, severe infection, risk of panophthalmitis, corneal involvement, intractable secondary glaucoma, all these are indications. Now, when to do vitrectomy is always controversial, but it should not be too late, because you will not be able to salvage the eye or vision. That benefit versus safety window is very narrow. So usually in a hazy media with some 3/60 vision, you can wait for 48 hours after an intravitreal injection to see if there is a response, and if there is no response coming forth, then I think we should move in for a vitrectomy. Corneal involvement, secondary glaucoma, panophthalmitis, and systemic signs, these are, as I said, better early than late. Immediate vitrectomy, fungal endophthalmitis or gram-negative, where the activity of endoph and the severity of damage is going to be very, very fast. You have to do a faster vitrectomy. Total absence of reflex or inaccurate projection of light, these are conditions in which you should again go in early. Now, a commonest approach would be worsening despite an intravitreal injection. The first case, in the first picture, we gave an intravitreal injection, it responded, but then it became worse. Then you will probably move into a vitrectomy. Can we operate a patient with no PL? In many cases, the PL negative can be caused by optic nerve toxicity, and I have found that some visual recovery occurs in some of these patients. Now, one investigation that you have to do surgically would be an ultrasound B scan. Look for PVD, retinal detachment, choroidal detachment, any areas of traction, etc. The VEP, etc. does not have so much of a role. These are ultrasounds which show vitreous exudates, or traction, retinal detachments, or retinal detachments, etc. Surgical technique, generally we prefer the local anesthesia. Basically, we have to strengthen the corneal incision, because during surgery it should not give way. A 3-port PPV, sharp MVR blade, 6 mm cannula, these are what are usually preferred. Infusion bottle, not so high, and you have to remove the pupillary fibrin, and high cut rate and low suction is what is preferred. Usually we have moved towards more complete vitrectomy, silicone oil injections. There is always a controversy between IOL removal and non-removal, and finally offers a good anatomical and surgical outcome. So here it is the anterior chamber fibrin, which is the pupillary fibrin, which is completely obstructing the pupil, which I am removing with an MVR blade, and then using a visco, you can take it out through the same opening. Now you can see that it is almost, the edge of it is basically taken out, and now once the media is clear. Now you can see the probe very clearly. So now we proceed towards vitrectomy inside. Now this is again another case where there is a pupillary fibrin, dense fibrin. This we are going in with a 25 gauge surgery. You can see that with the MVR we are trying to remove that fibrin. Sometimes if blindly you are doing, it may injure the iris, and iris can cause a lot of bleeding. So here we have removed the pupillary fibrin from the central area, and then once that is clear, then the next step is to see if the infusion cannula is inside. In this particular patient, we found that we could not find the infusion cannula there. Without that, you cannot open the infusion cannula or you cannot start the surgery. So what I did in this particular case was to probably remove that infusion cannula and put in another 6 mm infusion cannula there. And now if you can see, we can very clearly see the cannula tip. And now we can proceed with the surgery. Now once inside, this could be a very simple situation where you can see the disc at least, because the pupillary fibrin and the dense anterior segment reaction may have been causing the loss of vision, and this is seldom found. In such a case, it is very simple. You can cut all the vitreous out, you can clean the surface, and you can see that these are some areas where there was more activity and vitreous was more adhered to that, and this would be the end of surgery at this particular time. The next situation would be more vitreous exudates. This would be again, since there was a little bit of haziness here, I was cleaning the anterior chamber once more. The anterior as well as the posterior aspect of the lens was cleansed, and now I went inside. We could see that media was much more clearer. You could see the disc here and some exudates here, and finally ending up with complete cleansing of the retinal surface. So generally in these cases, we need not go up to a base dissection because these are more simpler, in the sense the ciliary body is not significantly involved probably. Now this is a case in which there were multiple small fungal balls which are coming. This is a fungal endophthalmitis. You could see the fungal balls floating up in the vitreous. That is finishing surgery in that particular case. Now this is a case in which I had created a tear here because the infratemporal infusion cannula could not be visualized, and I had to use an MVR to detach it, and I have created a tear. Now situation becomes more complex. I have to completely remove the vitreous traction on the retinal surface completely, and you can see here as the case progresses here, this tear, all the traction on the tear is now relieved, and once that is all relieved, I used a PFCL to flatten the retina and then complete the surgery. So you can see that the media is now very clear. So peroperative problems, you will have a lot of poor visualization because of edematous cornea, IOL membranes, sometimes ring abscess, adherent and sticky vitreous without a PVD. You may have to resort to just core vitrectomy without actively trying to induce a PVD. An inflamed and necrotic retina usually can develop tears. So doing a PVD or removing the hyaloid and toto from the retinal surface has to be a very carefully performed thing. And if it is very difficult to perform, don't perform it. The risk involved in making a tear, you should never take. Okay. And if epithelial edema prevents adequate visualization, epithelium can be removed. And after closure of sclerotomy, checked for corneal wound again, because sutures may have become loose or it may have become distorted. At the end of vitrectomy, intravitreal antibiotic injection is given, 1/10 of the dose. Now core vitrectomy, near total vitrectomy, PVD induction and retinal surface cleansing is what I generally perform in most patients if possible. These are some of the results, and in this patient who had PL minus, this went up to 6/36 in that eye. But sometimes the media becomes clear but the results are bad. To conclude, prevention is better than cure. There should be a high index of suspicion, and early management is very important. Explanation to the patient is very important because end-off is one condition in which the dialogue with the patient is most important. Urgent intravitreal injection, timely referral for surgery, and realistic results to be explained. Thank you very much.